so much. To Georgetown University's law campus here. We are in the International Law Building. We are visiting, and we have our student center right across the way with a great gym, so the students are pampered. This is the O'Neill Colloquium for National and Global Health Law. It's intended to first engage a group of students who are JD students here at the Law Center, and also LLM students, including our unique LLM program in global health law. By rule, students get to ask the first question, and they're our first attention. And just as welcome is the rest of the university campus, from the main campus and the medical school and the School of Nursing and Health Studies. We welcome you as well. Today we have an extraordinarily important problem in global health, and that problem has to do with trying to make a stable and secure and sustainable human workforce around the world, looking at the role of education and training, migration, recruitment, and then also looking at innovative solutions to problems of maldistributions or shortages, both in low and middle income and emerging economies, as well as more developed countries. We want to think creatively in terms of policy solutions, training solutions, and also potentially legal solutions of a national, regional, and international nature. And those international solutions might range from looking at the human rights structure to the International Labor Organization to the international health regulations, all the way through to the GATS and World Trade. That may play a part. We've just come from another meeting hosted by the Task Force for Child Survival and Development and the O'Neill Institute for National and Global Health Law, where we've been thinking for a full day about the nature of the problems and trying to think about innovative solutions, which is very much, as you know, here at Georgetown's O'Neill Institute. And so we're quite privileged to have a robust national and international group of people. We have more people. Sometimes it's just kind of me sitting with someone else like or Mark Dybel, but this time we have a full group, and so I'm not going to be able to individually grill them the way I do on one-on-one, but we will listen to a series of really very interesting conversations. Then if there's time, I might lead the questioning, or I might turn to the students, depending upon the time that we have, and then widening it to the broader audience. We'll try to take a break in the middle, and then at the end of our session, there'll be refreshments outside. We can continue the conversation, and students, of course, will have a paper topic that will be the reflective papers for. So with that, I won't give you very introduction since we would run out of time very quickly. But I wanted to start with Dr. Fitzmullen, an old friend. He's got enormous experience. He's currently at GW University, but has worked in government and is really internationally known for his thoughtful approaches to the human resource issues. So why don't you go first, Fitz, and then I'll introduce our next speaker.
Thank you, Larry, and it is a pleasure to be here. We recently received a memo, you will be interested to know, at GW saying that whenever we were referencing ourselves in memos or elsewhere and we didn't want to write out the George Washington University, we should write GW and not GWU. And the reason was we could not afford to be confused with Georgetown. So I'm acting under those rules. And but I am honored to be here. It's my first visit to the law school, and it's impressive. I didn't know what good digs you had. I might have considered differently where I went. I'm going to talk very quickly, run you through very rapidly a little bit of background on global workforce issues, which this terrific panel will talk about in many different ways. But this is easily an hour presentation. I'm going to do it in 10 minutes, so buckle your seatbelts. I suspect everybody in this room has some knowledge of the topic. Apologies if I hit too low or too high, but I'm going to go quickly. Health workers are not evenly distributed within or certainly between nations, and this is looking between this WHO information, and it gives you a graphical sense of the level of health workers and the burden of. And as you can see, the United States has a relatively low burden of disease and a massive quantity of Africa at the other end of the spectrum. In this for a moment, these are rough figures that give you denominated not per thousand. I've tried to change the slide any number of times. This is per 100,000. So in the United States, if you're in the middle, we're in terms of physicians, and I'm going to talk mostly in terms of physicians, about nursing, I suspect as well, and with apologies, this is where I spend most of my time. I use it as a kind of marker. But most of the things I'll say about medicine could be said about nursing or pharmacy or all of the health professions, including relative densities here. So 280 is what we have. There's argument in this country whether it's too much, too little, but it's basically where we are today. And you can see the spread around us. Cuba has the most munificent workforce, the richest, the most dense. Actually, I looked at some figures. It is North Korea, which is up in the 600s. Now, I don't know what the North Koreans are doing. Don't know anything about the quality. But the Cubans have a pretty good product that is all over the world because Cuba's been very creative in exporting them in a very strategic way, both humanitarian and political. And that's a whole story in itself. You're probably somewhat aware of it. But they have a family doc on every corner. They're very doctor-centric. They do have nurses, but it's a doctor-centric workforce. And they don't have mid-levels or other kinds of practitioners. It's pretty traditional, but very effective. At the far end, you have the countries of Africa, such as Mozambique, that have variably between 1 and 3 physicians per 100,000, hardly any physicians to speak of, and the spectrum between. Broad variation. Now, do health workers matter? And this is an arguable point. In the main, and certainly when you're at low densities, yes. And this is a rather simplified slide, bringing a lot of data together, but if you look at these 3 classic markers, maternal, child, and infant survival, they all improve as the density of health workers increases. Now, of course, that looking at different ways, density of health workers increases with better-to-do economies, so it's not an independent variable, but certainly it's associated. What drives the movement, which is a very important element of health workers, from what I'll call the global south, which is countries of, by and large, lesser developed countries, mostly in Africa, Latin America, and Asia, as graphically outlined here, are, in terms of medicine and in general, lack of opportunities for further training, poor practice situations or opportunities, poor remuneration, unstable political health, and particularly HIV/AIDS. And the pull, as is talked about to the north, Australia in the north, is really the flip side of that. Better opportunities all along the line in terms of training, practice, remuneration, technology, and for the family as a whole. Now this is a stripped down piece of work I did several years ago looking at international migration to these four Anglophone developed countries. And the important point here is that if you look at the workforce of these 4 countries, about a quarter of the physicians in all of these countries come from abroad. And most significant, if you look at what percent come from lesser developed countries, in the United States it's 60%, in the UK it's 75%, somewhat less than the other 2. So not only do we draw from other countries, and we do draw from Canada and the UK, but we draw substantially from the lesser developed or poorer world. And if you look at it from the sending countries or the donor countries or the source country perspective, the issue really isn't positions, but it's what percent of your workforce are you losing. In this work, the bar is very high. I only measured physicians who showed up in the licensed or certified workforce of the country. So in the United States, you had to be licensed and in practice in the AMA master file. There are lower bars, for instance, if you use just census data, how many physicians are in the country, and the numbers will be about twice this large. That is, the percents will be about twice this large, the immigration factor, so-called. But the point here is it is the poorest parts of the world that give up the most doctors to the north. This has been called reverse foreign aid. I mean, we spend a lot of time, and those of concern in this country are trying to do more about helping. And here, whatever else we're doing with the one hand, with the other hand, we're taking very substantial parts of the educated physicians in countries in sub-Saharan Africa, India, the Indian subcontinent, and the Caribbean. 2 volumes published recently that anyone who's in the field should have both. On the left is the so-called Joint Learning Initiative, funded by Rockefeller, largely Atlantic Philanthropies. Came out in 2005, really kind of focused the issue. In the following year, 2006, the World Health Report, very good baseline discussions of global workforce issues. I will say that I think importantly, it was more than any other single thing, it was the arrival of antiretroviral drugs, drugs that were effective in treating HIV disease at prices that were potentially affordable, or at least with a variety of international donor activity, pharmaceutical activity, you could get antiretrovirals on the loading docks in countries in the poorest parts of the world. The problem was when it got to the loading dock, there was nobody there to do anything with it, speaking metaphorically. The workforces in many parts of the world were absent, dilapidated, unable to, and even today, struggling even to dispense and manage, because with HIV disease, unlike, say, a vaccination campaign, once you put someone on treatment, it is committed to the rest of their lives with all of the complications, medical, social, and the like. So it's a huge commitment. Nobody was there. And that suddenly brought the whole global community to a standstill looking at workforce. And happily, under the worst circumstances, workforce issues are getting a lot more attention. So what to do from a U.S. perspective? The first and most important thing, I believe, although in our room today there was not universal agreement, the most important thing is to train for self-sufficiency in our country. We've got to get away from the reverse foreign aid. Otherwise, we're wiped out effectively, or certainly effectively damaged. So we need to train towards our own needs, and not at 3/4 of our needs, or as a nursing at 90% of our needs, because that vacancy rate is a huge opportunity, and one respects the opportunity and the desire of people to move, but it represents a huge drain on many parts of the world that are struggling with their own problems. The second is to support planning, training, retention, and management initiatives in the South. PEPFAR, the President's Emergency Plan for AIDS Relief, as you probably know, the largest effort on our part, has a lot of emphasis now on workforce training and support and scale up, as do other international efforts. But certainly as Americans, both in terms of our government, in terms of our universities, twinning, and in terms of our own work, very important that we keep working on capacity development support in the developing world. And then finally, the notion of a U.S. Global Health Service. I'll spend a moment on that. Time is short, but I just want to show you what the impact of our own policies can be on the developing world. This is U.S. data. I won't tarry on it except say this is a 280 or roughly physicians per 100,000, and you can see we had a long ramp up and over time. People argue that this is not sufficient with an aging population. We need to go to 310, 350, 400 physicians per 100,000. And should we do that, the implications for the developing world will be significant. Here's the entry into practice in the United States is through residency programs. Because residents come from U.S. so-called medical schools, allopathic medical schools, osteopathic medical schools, and significantly international graduates. And you can see in residency right now, about a quarter, a little better than a quarter of our residents are international graduates. The line has been trending slowly upward. So this is what we train domestically. This is what we add in. It represents about 6,000 new entrants every year coming from abroad. Now, that has given us this situation. About 18,000 U.S. graduates, about 6,000 go to make the 24,000 interns, PGY1, postgraduate year one. If we do as we're doing now, increasing medical school enrollments, and we are, by about 2015, we'll be graduating 21,000 plus. And if we keep the residency slots about the same, it will diminish the pull on the world. If we increase the residency slots along with the medical school slots, we'll see this. And if we go to 30,000 first-year graduates, as many people are advocating, we will increase the pull on the rest of the world to 84,000, or 8,400 per year. This is largely determined by U.S. Medicare policy. I won't stop on this. Some of you may be aware of it, and we can talk more about it if you like. But this is a domestic policy that usually is not talked about in terms of the world. It has huge potential impact on the world. So we need to attend to this. This is where foreign policy, domestic policy come together. I won't tarry on that. I was fortunate to chair a committee a few years ago. Marla Salmon is here with us, was on the committee as well, an Institute of Medicine committee that was asked to look at how we could ramp up, scale up the number of U.S. folks working and healers abroad in 2005. I think. And basically we came up with the concept of a United States Global Health Service. In shorthand, kind of a Peace Corps for health. And the essence of the concept was to develop a program that was responsive to country needs, interdisciplinary, aimed at self-sufficiency training in countries. It would try not to deplete the workforces of those countries, and most important, that there would be a multiplier effect. Anyone who went abroad, the major mission, whether they were a nurse, a physician, a hospital administrator, would be to multiply their skill set in the setting where they were working. This goes beyond what I call Schweizerianism, which is to go and lay on hands to cure and provide succor. Very important that you could unload thousands and hundreds of thousands of doctors and nurses, and you would help a little bit, and they'd go away and it'd be back to where it was. This idea, this is building towards sustainability, towards self-sufficiency within the country. It would include clinicians, technicians, particularly we were told from much testimony took, IT and pharmacy were important areas, and also how to manage health systems. The program would have a Global Health Service Corps. These would be folks employed like the National Health Service Corps, U.S. government employees deployed for periods of time or 2 years or more with expertise in target countries. Additionally, we saw a great deal of help that could be given to people going independently, either through faith-based organizations or through Doctors Without Borders, what have you. And toward that end, both the loan repayment program, which would pay the banker, so many young clinicians have very substantial debts, and they can't go if nobody's paying their loans. So this would be loan repayment, plus a fellowship, a Fulbright fellowship, would give them both dollars and honor for going abroad. Support between institutions, and finally a clearinghouse that would provide one-stop shopping for people interested in the area. The Global Health Service would provide direct humanitarian help. It would provide health systems development. Security implications are important in this area because both a better name for the United States, frankly, as well as better health are both in the interest of U.S. security. So while it has an idealistic and humanitarian element, it also has a security element. And finally, health diplomacy, an important thing for us in a world with a lot of competing interests. We also talked about the Peace Corps factor. That is, when folks return, they would bring back with them this global experience and a whole lot of a different perspective. And as with the Peace Corps, you see many people who have risen to senior positions in public life and private life today who are Peace Corps volunteers. Generally, their worldview and their jobs are different. Our dean, for instance, the medical school at GW, a Peace Corps volunteer in Sierra Leone, and he's very clear it was the most important formative experience. We think this would be good by itself. Best thing to do is to have planted a tree 20 years ago. The next best thing to do is to plant it at the beginning of the Obama. We'll plant it today. Thank you.
Thanks very much, Chris. We appreciate that. Case Lynn Hardy. She is one of our own from the School of Nursing and Health Studies at Georgetown. She served with the World Health Organization in Geneva relating to issues on nursing and midwifery. Thank you.
Thank you. And I don't have PowerPoint slides, so you're going to have to listen to me, and I hope that the statistics that I tell you about, and I'm talking about nursing more specifically, I hope they come across in what I say. I'm going to talk first about nursing demographics in the United States and then migration issues, and I'm mostly going to focus on the United States. Defining a nursing shortage, I think there are some in this room who probably would be better than I am at doing that, but it's been a very complicated thing. And Fitz pointed this out in terms of physicians and the ratio of physicians to populations in various different countries and how they compare. And in the United States, we have a lot of nurses as compared to other parts of the world, yet we claim that we have a significant nursing shortage, to the point where in 2020 we are expected, in some estimates vary, but that we'll have a shortage of between 800,000 to 1 million nurses. Why? Why do we have that problem? Largely because we have an aging population. Fitz also mentioned that. The population is aging, so they have more demand in terms of health care, but the nursing population is also aging, to the point where mid to late 40s, those are practical. And in terms of nursing faculty, we even have a scarier shortage and aging problem. The average age of nurses getting PhDs is in the 50s or so. The average age of nursing faculty is also in the mid to late 50s. So we know that those people are going to be retiring, and as Peter Buerhaus pointed out in our meeting earlier today, we have to plan particular need, because if we don't have faculty to train nurses, we're also not going to have enough of them. There have been a lot of recent reports about how many people want to enter nursing now, which is wonderful. I mean, it's a fabulous renaissance. It hasn't existed in a long time. But if we don't have adequate numbers of faculty, we can't train those nurses. Nurses on the whole comprise the largest proportion of healthcare workers in the United States and in most countries. Now, in Latin America, the numbers are a little bit different, and my colleague from Chile pointed that out. The ratios between physicians and nurses are slightly different. According to the National Sample Survey of Registered Nurses that came out in 2006, but based on 2004 data, the current U.S. registered nurse population is 2.9 million. Of those, at the time, 83% or 2.4 million were employed in nursing. Though in 2001, there was a peak in U.S. hospital registered nurse vacancy rates. At that time, it was about 13%. What does a 13% vacancy rate mean in terms of the health care that you and I are seeking out on a regular basis, or our family members or our friends? It means that if we go to an emergency room and a unit is closed because there aren't enough nurses there, get admitted to the hospital. So it has huge societal implications when we don't have enough nurses. And I'm talking mostly about hospitals here. Of course, we know that nurses function in a lot of other capacities in our society. So let me just move forward here. Another element of this is that people are sicker in hospitals than they used to be. We all know that a lot of procedures that are done in the United States are now done on an outpatient basis. That means that people who are actually in hospitals are sicker than they used to be, and that means that they need more attention and more care. That means that the time that nurses need to spend with patients is more valuable to those individuals, and so they really need to be present with patients. Although most of the time, I will tell you that a lot of nurses say they don't have enough time to spend with patients. One to point out in the United States is the state of California, which adopted legislation mandating nurse-to-patient staffing that came into effect in 2004. What does that mean? That means that in certain units, so in units where there was high patients needed a lot of care, the nurse-to-population ratio was much lower in other units. So, for example, in some intensive care units, the nurses to population, or nurse to 1 to 2 patients. So because of the legal implications, California do have enough nurses to take care of those patients. So the in the state of California have been using both agency nurses and foreign trained nurses. Agency nurses are very costly nurses. The hourly rate for agency nurses can be up to $40 or $50. Agencies also pay nurses to have housing and to stay in environments for longer periods of time. Nurses can have a very lucrative career, actually, in traveling to different. According to, let's see, I've already talked about that. In the other element, aside from agency nurses, is the foreign educated nurses, and Fitz brought this up in terms of physicians. About 10 or so of the nursing population in the United States is now made up of foreign educated nurses. In 2007, the American Hospital Association that 17% of hospitals reported hiring foreign educated nurses. In addition, 22% of foreign educated registered nurses were employed by nursing homes. So that's a population that we don't talk about a lot, but in a lot of cases, hospitals are one environment where foreign educated nurses are employed, but nursing homes are another environment. So why would a hospital hire a foreign educated nurse over using an agency nurse? Agency nurses are very costly. Foreign educated nurses are also costly, but not quite as costly. And there have been some estimates that hospitals can save $50,000 by bringing in a foreign educated nurse over an agency trained nurse. Currently, the percentage of foreign educated nurses taking and passing the national licensure examination, which is called the NCLEX RN, is about 12%. And of the population coming into the United States from abroad, 51% of that population is from the Philippines. And the Philippines is unique in terms of the export of nurses because they actually train nurses. In fact, not only do they train nurses, individuals to become nurses, a lot of physicians in the Philippines have now started going back to school to become nurses because they know that they can leave the Philippines and come to the country in the United States and actually make more money than they can as physicians. There was actually an article in the Washington Post a few weeks ago about physicians in rural areas in the Philippines going back to school to become nurses so they could leave. So they then exacerbate the imbalance between rural areas and urban areas, which is another major problem in a lot of parts of the world with healthcare in general. 35% of the nurses coming into the United States are nurses that come from countries that WHO deems as having a human resource crisis. There are 57 countries in the world that have a human resource crisis, and as I said, 50 nurses that come into the U.S. are from those countries. Fitz pointed out some nurse-to-population ratios in terms of less developed countries versus more developed countries. I'm going to do physician population. I'm going to talk about nurse-to-population ratios. In low-income countries, the nurse-to-population ratio can be less than 100 per 100,000 population, whereas in Europe, which is the place where they have the highest density of nurses per population, it's over 663, and I'm talking regionally, I'm not just talking about individual countries, 663 per 100,000 population. There are a couple of areas of the world. As I mentioned, the Philippines has been a big sending country into the United States. But there are a couple of other countries that are increasing targets in terms of the recruitment of health personnel. One of them is India. Naturally, one of the reasons is because a lot of people in India speak English, so it's an easily marketable skill to have somebody who is a nurse and who speaks English to come to the United States. But another country that is beginning to think about this, and we're seeing increasing interest, is China. So nurses have been trained to speak English and to be nurses trained like they would be in the United States in order to pass the national U.S. nursing boards. Fitz has already talked about push and pull factors, and I just wanted to talk about them just to highlight them. Some push factors include poor economic conditions, lack of adequate support within the healthcare system, which is absolutely huge. I don't know if any of you have read any articles by a woman named Celia Duggar. She's a reporter for the New York Times, but she writes frequently on this topic. And a few years ago, she did this series of images that are still, I think, online if you look at the New York Times website, of nurses in Malawi and looking for a maternity ward, and how one nurse would have to man an entire an entire maternity ward, and there would be women giving birth without any attendance whatsoever, despite the fact that they were in kind of a healthcare system. HIV can be a push factor as well. A lot of healthcare workers have HIV, and those who don't have it are also discouraged by the fact that people are dying around them constantly, and I'm talking specifically about sub-Saharan Africa. In terms of pull factors, you have better economic opportunity. Fitz already highlighted this. When you have friends and family, when you have a diaspora in another country, that's a big draw for people. So because there are a lot of Filipinos in the United States, there is this community of people that they can attach to when they arrive in the United States. Family considerations are also huge. When individuals want to have not only a better life for themselves, but for their family members, for their children, they look to other countries where they know that they're going to be able to get a better education. So that's a huge draw as well. There are more opportunities for career advancement. Fitz already talked about that. And another thing that he didn't mention, which I want to point out, although you did talk about it a little bit, is remittances. Remittances are huge in sending countries, and one of the reasons why there are some people in sending countries who don't object to having health workers leave, because they know that those individuals who leave will be sending money back home. So that's an ethical question that I just wanted to make sure you think about. When I was at the World Health Organization, Pascal may talk about this as well, but I worked for the chief nurse officer. And we would get phone calls on a regular basis from organizations asking us to take a position on the migration of health personnel. And my boss would say on a regular basis, it's impossible to do that. Because you're talking about the rights of individuals to leave a country and migrate to have a better life someplace else versus the rights of both source countries and destinations. These competing interests don't allow us to take one position because it's an incredibly. So I'll just leave you with that thought.
Our third speaker is Paula O'Brien. Paula, I think many of you know, she's a very talented young legal scholar at the O'Neill Fellow and co-author of the Milbank report on this topic. Thank you, Paula.
Thanks very much, Professor Gostin. So my comments this afternoon are going to focus on two of the causes of the global shortage of healthcare workers. The first one is the inadequate availability of pre-service education to train sufficient numbers of people to be professional healthcare workers, and then the second is the inability of the health profession to retain trained healthcare workers, either at all or in accordance with a pattern of distribution in the country which serves the population's health needs. So I'm going to describe to you how each contributes to the problem of the global shortage of healthcare workers, and then I'm going to describe some of the strategies which are being used to address it, so that you can have a sense of what is being done to address what are very core issues. So I'm going to start with service education. So there's many people in the room who will understand what that is, but just for people who haven't come across the term before, this is education to qualify a person to act and be employed as a certain type of healthcare worker, as opposed to on-the-job training of healthcare workers. In many ways, this is a foundational cause of the global shortage of healthcare workers, and it has been flagged already by Fitz and Katie. In simple, very simple terms, countries are not numbers of the types of healthcare workers who are needed to meet domestic labour demands for health professionals. It's said that Africa is turning out 10 to 30% of the number of health professionals it requires to meet the population's health needs. The USA, I think it was of 800,000 to 1 million nurses in 2020. However, the American Association for the College of Nursing reported that in 2004, more than 30,000 applicants seeking baccalaureate education in nursing could not be accommodated in the US, and the National League for Nursing estimates that in the same year, 150,000 individuals were turned away from all types of nursing programs in the US because of shortages of faculty, resources, space and clinical education opportunities. They admit the numbers may be slightly inflated because of multiple applications to multiple nursing schools, but nonetheless it is signalling quite a high number of applicants who can't actually get into schools. A country's failure to make proper provision for healthcare education may be due to a country not having engaged in adequate long-term health system planning to determine the country's future needs for healthcare professionals. They may not have also determined the labour market demand for healthcare workers, the education and labour policies required to meet the demand, as well as the public and private sector financing which is needed to implement essential policies and programs. Some states have simply failed to engage in adequate health system planning. And we heard today at the Millbank meeting that one of the key issues is different parts of government, different ministers and departments in government not speaking to each other about what are going to be the health needs, what are going to be the labour market demands, what are going to need to be the educational programs. That we can't get ministers of health, ministers of education, ministers of labour to basically talk and form a coherent strategy. It should also be acknowledged, though, that some states are without the technical capacity to do strategic planning. They lack data, which is important for such planning exercises, or they lack the expertise to analyse and use the data to construct a plan and build a workforce for the future. Sometimes lack of educational programs is also due to chronic underinvestment in healthcare systems. In many instances, it's the government who has not properly contributed to establishing the necessary educational infrastructure to create a nationally sufficient health workforce. And that this problem sometimes goes back to the primary and secondary school level and is not just at a tertiary level. In some countries, they're not producing with secondary school education, which would equip them to go on to further education to then start the workforce. This education is due to a government's decision to divert available public resources to another policy agenda, and many rich countries, Australia, where I come from, fall into this category. However, don't spend enough money on health education and health workforce, that they'll probably still be okay because they have a migrants who want to move to their country, who, because of the push and pull factors that you've heard about, are very interested in coming to the country, and so the workforce will somehow be filled, even though the state is not doing enough to produce enough healthcare workers. However, it's not to deprioritise investment in health sector education. Many poor countries do as well. However, many of these countries may be in a situation where they do not have available to them the significant financial resources needed to build and sustain an education system for healthcare workers. It should also be recognised, particularly in the past, now, that some poor countries have found themselves subject to strict conditions under loan and debt forgiveness schemes, such as those through the International Monetary Fund, research on health infrastructure and systems. The problem with there being too few places in educational programs for healthcare workers and too few graduates is only one part of the causes, but it is a very complex and it is a very costly cause to solve. Furthermore, even assuming that educational opportunities can be made today, they will not actually produce results until many years down the track when the healthcare worker graduates from the program. This obviously, the length of time depends on the type of health worker, but with a doctor in the US, you're looking at, people were talking today, 8 to 10 years before you have a specialist doctor in many areas. So we're not talking about solutions implemented today which will have real effects tomorrow. We are talking about long-term solutions. One of the most important policy questions for a country which is planning its health workforce education is, does it want to be nationally self-sufficient in the production of healthcare workers? And FITS has raised this, and it really is a pressing question when states are working out what their health workforce plan is going to be. For some countries, this question does translate to, does the country want to produce enough of its own healthcare workers, or is it content to rely on migration and recruitment of workers to meet the country's health workforce needs? For rich countries, this question raises in part ethical issues, which I think should not be overlooked. Where the country knows, or it should know, that it is recruiting healthcare workers from countries with critical health workforce shortages in order to meet the local demands for healthcare services, is it ethical for the country to continue to rely on the influx of migrant workers? Or should it, as an ethical response, start to build its own nationally self-sufficient workforce? Arguably, some of the global deficits would be reduced if countries like the US, the UK, Canada, countries in the EU, countries like Australia and New Zealand educated larger numbers of healthcare workers to satisfy domestic demand for health professionals. Furthermore, with more healthcare workers trained in rich countries, there may be scope to go to poor countries to fill gaps in the health workforce in the short term, hopefully until poorer countries can build their own sustainable workforces. On a promising note, in the recent election campaign, President-elect Obama did make some promises around expansion, including loan repayments, adequate reimbursements, grants for training curricula, to ensure a strong health workforce that will champion prevention and public health. So if we're going to hold him to that, there may actually be some good news in the US that there will be some more funding for pre-service education in the future. But there's not much detail there, so we wait and see. Many poorer countries are engaged in a number of local people who are trained as health professionals, hopefully to remain working in local health systems and not quickly migrating to another country which is looking for healthcare workers. There are a number of developing countries which have started working on training for more healthcare workers for in-country service. I just want to mention a few examples to give you a flavour of how developing countries are responding to this problem. The Malawi government, with huge support from the Department of International Development in the United Kingdom and the Global Fund, is doubling the number of nurses and tripling the number of doctors in training as part of its 6-year so-called Emergency Human Resources Plan. There is also a PEPFAR promise to invest $1.2 billion over 5 years in health workforce development. Ethiopia has a training program to train up 30,000 community health workers. They're also called health extension workers. 2009, so that people living in villages will have access to basic health services as quickly as possible. Similar approaches to that in Ethiopia have been seen in Thailand, which rapidly expanded its pool of community health workers in the 1970s and 1980s, while simultaneously putting resources into longer-term education of other health professionals. Pakistan has produced 80,000 lady health workers, which provide care to 70% of the population. The lady health workers receive 15 months training, 3 months full-time, 12 months part-time, and they study the essentials of primary health care and hygiene, community organisation, interpersonal communication, data collection, and health information management systems. They report to a supervisor weekly. Community healthcare workers can be educated more quickly than healthcare workers, and in Africa, and the cost of educating a community healthcare worker in Africa is 1/5 of what it costs to educate a doctor on average. The numbers of different types of healthcare workers which a country educates is another important part of this policy question when a country is doing its planning for health. Countries need to determine what mix of different categories of healthcare workers it wants to have in order to most effectively meet its people's health needs. In thinking about that question, some countries have been increasingly embracing the concept of task shifting. Many of you will be very familiar with that, but some of you may not be. In simple terms, it involves the delegation of tasks from more to less specialised healthcare workers who are trained to take on the additional tasks. The attractions of task shifting are quite clear. They enable the quicker and cheaper expansion of the health workforce and arguably the more efficient use of human resources. So healthcare workers are then performing tasks which fit their skill level and not tasks which can be performed by somebody at a lesser skill level. Task shifting has seen the training of non-physician healthcare workers in some surgery, abscess drainage, hernia repair, caesarean sections. It's also seen clinical officers prescribing antiretroviral drugs and volunteer health workers using village-based microscopy to diagnose for malaria in Myanmar and the Philippines. So the research suggests that task shifting can be very successful in relation to some, but not all health interventions. And some of the research regarding successful task shifting from specialist physicians to nurse practitioners and physician assistants for HIV care suggests that preconditions for positive outcomes with task shifting include high levels of experience and focus on a single disease. There are real concerns, obviously, about the quality of care and patient safety, which can be jeopardised if inappropriate tasks are transferred to an inadequately skilled healthcare worker. Completely reasonable concerns, and they do need to be addressed in determining what tasks are suitable for delegation from one type of healthcare worker to another type of healthcare worker, and what kinds of systems of supervision and oversight are needed. But I don't think concerns are fatal to the concept of task shifting, and it seems that many countries also share that view and are continuing to embrace the concept to do their health system planning. I'll just be very brief about the second topic I was going to talk about. This was about the inability to retain healthcare workers in the profession. So we know that the profession has had quite limited success in keeping trained workers working in the health profession. There are many reasons for this, and a number have been in the push factors that lead workers to migrate. All of those factors that might lead workers to migrate are the same factors that might lead a health professional to basically give up on the profession, look for a new career. So, but I'll just flag some of those for you. I think a particular part of the problem about retention does relate to underinvestment in the healthcare system. And underinvestment by the government, but also the private sector, is reflected in hiring caps for personnel, poor remuneration levels for healthcare workers, stops on upgrading capital equipment, supplies of pharmaceuticals and other disposable equipment. And all of these factors produce an onerous and unattractive working environment in which there are too few staff are unhappy about remuneration, non-salary remuneration, staff can't do their jobs properly. And these conditions combine to produce stressed workers with low morale who feel burnt out by their jobs. But there are other factors which are exacerbating the problem, and they include lack of social recognition of healthcare work, lack of career ladders for healthcare workers in many countries, lack of training and development opportunities, lack of autonomy in workplace decision making, and in some instances, workplace violence. In Sweden, there's a 24% chance of experiencing workplace violence if you're a healthcare worker, whereas police have a 5% chance of experiencing workplace violence, and security personnel have a 2% chance only. So all of these factors may just turn people off entering the profession, or they may actually drive people to leave the profession. And some people will leave completely. Some people may start to scale back their hours in the profession, which is also a part-time work in another profession. But as we also talked about today, and which is quite a considerable problem, healthcare workers, probably not unreasonably, for a place with the best remuneration and the best terms and conditions to make up for some of the rigours of the job that they have to face. But what this means in some countries is that, for example, in Ethiopia, workers will often go and work for an international NGO as opposed to working in the public sector, because in the international NGO they can get 4 to 5 times the salary that they can get in the public sector in Ethiopia. In Malawi in 2000 there were 30 nurse graduates, 2 went to work in the public health system and 28 went to work for NGOs because of the higher pay that was available to those healthcare workers in the NGO sector. There's lots of different projects that are being undertaken to try and address these problems, and once again I'm just going to flag a few so you can get a taste for how this problem is being responded to. Malawi is a very interesting example again, with the assistance from the UK and the Global Fund as part of its emergency human resources program. It's raising gross salaries for 11 cadres of healthcare workers, recruiting over 700 new employees, and it has 200 more places to fill at the time of this research. So it was relying on a massive infusion of capital into the country to basically lift up the health workforce. An obvious question about this is how this is going to be sustainable into the future. In other countries, donor money is helping to ensure that salary payments are made on time. In Chad, salary payments for workers are often delayed 4 to 7 months, and we heard from a colleague today at the meeting that in Tanzania sometimes the payments were delayed 12 to 18 months. So donor funds can significantly help to address these kinds of problems. For people who are interested in following this up further, I'd suggest that other areas of interest for research include looking at the nurse-patient minimum ratios that Katie talked about. Georgetown NHS is involved in a very interesting project around wellness centres for workers, so ensuring that workers themselves have access to healthcare services so that they can continue in their work. The International Council of Nursing is doing very interesting work around leadership training for nurses to ensure that they're in the profession who are able to provide the kinds of guidance and leadership that's necessary to keep more junior nurses there. And an called the Positive Practice Environment Campaign, which is a worldwide campaign to generate public awareness and political will to introduce and maintain improved working conditions within the healthcare system. So some leads that you might like to follow up if you're interested in looking at the other kinds of programs that are being pursued to try and solve this problem.
Our next speaker is Polly Pittman. Polly is the Executive Vice President of Academy Health, and she has been partnering with the O'Neill Institute. She did a wonderful report on nurse migration and recruitment, and you joined with us in looking at an ethical code of practice that she's going to talk about.
Thank you. I'm going to need to do some jumping jacks or touch the toes. I see a lot of droopy eyes here. It's been a long day for us as well. But hi. So some of what I'm going to talk about has already been introduced by Katie. I wanted to tell you a little about the research we did that led up to this initiative to do a code in the United States, and then describe the process of developing the code and actually what the code contains. So I think, Katie, you pretty well covered this. Is that there is a business of recruiting healthcare professionals. Physicians tend to go medical school to medical school. There is no intermediary yet, although I understand that there are some companies that are interested in exploring this option. But nursing is big business, and recruiting pharmacists and recruiting OT and PTs is also a big business. And these companies that specialize in international recruitment, about 90% of their business is focused on nursing. As Katie said, the trend in terms of recruitment of foreign educated nurses is on the rise. This is really regulated by migration policy. And there's going on in Congress about migration policy. So whereas the physicians come with student visas, the nurses are mostly coming with green cards under Schedule A, which those of you who study migration law know better than I, is basically sort of a process for those professions that we sorely need in the United States. We have used up all of the A, and there's a backlog, especially for the countries that are the primary exporters of nurses, Philippines, India, and China. And so there's a strong lobby on the part of the hospital associations and hospitals that have now created their own association to convince Congress that they need to expand the number of visas. And I think actually sympathetic to it, on the IT side, there's also a strong lobby to get more visas for IT workers, although those are usually temporary visas. In the case of nurses, the unions have been very active in this country and really insisted that temporary visas are not fair and they need to be green cards. Otherwise, there's unfair competition with domestic nurses because they tend to be paid less. So a nurse issue, I would say migration policy is a huge issue and a complex. As Katie said, most of the nurses are coming from the Philippines, and about 35% are coming from defined countries with acute healthcare shortages. These are the actual numbers. So the percentages, because we're such a massive country, are actually only moderately informative. What really matters is the absolute number. So you could have 30 nurses coming from Malawi, for instance, 100% of their nurses, but it's a drop in the bucket for us. So very few nurses for very small countries is actually a large impact. So the absolute numbers are important here. When you look at percentages, Africa is not very important, but when you look at the absolute, and in particular Africa is actually among those countries, there are the 57 with severe shortages. Africa is the one that is the primary supplier of nurses for us. The region is the primary supplier. I'm going to talk about the research we did on the industry. So nurses come often by themselves, but it's hard to get a green card, and so often they contract with an intermediary company. And the concept is active recruitment. And this is what active recruitment is. These are job fairs, these are local agents that get a commission, and they may be local nursing schools or they may be hospitals, but there's a chain of that are basically offering nurses a contract that is binding and that the business will act on their behalf and find them a job. So it's a dual function. The research we did, basically our starting point was a survey that the Commission on Graduates of Foreign Nursing Schools did that said that about 40% of all the nurses that come here are active as opposed to finding their way here on their own. So we were really interested in that 40%, thinking that's actually sort of an important, because no one is proposing that nurses who come here on their own should be prohibited from doing so. But the active recruitment is a space that might be more subject to policy interventions. So the first thing we did was try to figure out how big this industry was, and we did a web search and we counted them, and there are about 300 companies that in one way or another are engaged in this business. And according to the largest companies and the oldest companies, around the year 2000 when the current nursing. So obviously we have a huge surge in the number of companies that think this is a lucrative business, and in part it had to do with the IT industry no longer employing educated workers, and some of those firms went from IT to healthcare. It also had to do with the shortage in some of the domestic staffing firms, their business, and created a separate legal subsidiary. And this is actually a good legal question for someone who wants to look into this, because I have never gotten a straight answer. That there are some interesting legal implications of a U.S. company that does staffing with domestic nurses and then creates a subsidiary that employs only foreign-educated nurses under completely different contractual terms. So the Canadian nurses are actually the only ones who get to belong to the side of the staffing agency that has the domestic nurses. But if you're from any other country, you have a whole different set of rules. Whether or not that is legal, I think, is an open question, and I think people have sort of shied away from that because there are some major companies that are traded in Wall Street that are doing this. So it would be nice if one of your students took up this question and gave us a straight answer, because nobody has dared to answer it. At any rate, there are basically two models of these companies. Some of them are placement firms, and they are paid per nurse, about $25,000 per nurse. And the other model are staffing firms, which are similar to the per diem travel nurse model that Katie talked about. But the big difference is they have a contract that is binding for 2 to 3 years, and there's an upfront breakage fee. If they leave that contract, they have to pay, and the fees, there's no regulation of these fees, and there's very little documentation of who's charging what. But of the 27 companies that we interviewed, fees ranged from $10,000 up to $50,000. So we're thinking that it's about $25,000 to $30,000 average. And for nurses that are coming from developing countries, it basically means that they are indentured. They can't leave their jobs if they find a situation that they, for whatever reason, don't believe is satisfactory, if they feel that they were duped, if their mother dies in their home country, for whatever reason, they can't leave their job. So another question for a law student to look into, is that legal? I don't know. I've never gotten a straight answer on that. But I think it's the core of this business model. It is the core. No one will not do it because they've invested a lot of money. And they would say, if the nurse leaves and goes to the hospital down the block, I've put out all this money to bring her or him over, and it's my loss. So it's a real business dilemma, but I think it's also an ethical and a legal dilemma that somebody should be looking into. Some companies do both. That's a third legal question somebody looked into. Nurses sign a contract with a placement agency. It also has a staffing agency attached to it. They actually don't tell the nurse where they're going to be working, and when they get here, it just depends on what jobs are available. So this issue of, as you all probably know, to get a green card, you have to actually have an employer who sponsors you. Some of these employers are then selling their nurses, on day 2 of being in the United States to somebody else. And so there are, again, a number of legal issues that I think would be interesting to look at. Yeah. Sure.
Do they have rights to bring their dependents with those programs as well?
Yes, because it's green cards, they can bring dependents, yeah. The trends in the industry seem to be, there's a concentration of companies happening right now. The big guys are buying out the small guys. So the small placement agencies that have local expertise are of great interest to the large recruitment staffing agencies. The staffing agencies obviously are much more lucrative. To get a green card to actually be an employer as a staffing agency, you have to have assets that are worth at least 1 year of that nurse's salary. So you have to have capital to be a staffing company. So the staffing companies are buying up smaller companies and becoming large. There are 5 of them that are actually publicly traded. So whether the concentration here of capital is a good thing or a bad thing, I think, is not a legal question, but a good research question. Implications of having larger companies that might be actually beneficial to those nurses, because it's more likely that there'll be transparency and accountability of that company's. On the other hand, their efficiency in terms of moving people from one continent to another is going to increase, and it may mean that there's an even greater pull on nurses from other countries. So the other thing that we did in research was look at of the 300 companies that actually indicate on their websites what countries they're actively recruiting in, we look to see where they were recruiting. So this is different from the numbers that we have from the NCLEX exams, which basically say of all the nurses that have come here, where are they coming from? This is of all of this subsample of nurses that were actively recruited, where were they actively recruited from? And 47, so there are 147 websites that actually said where they were active. And of those, 47 were active in at least one of the WHO 57 countries. It was also interesting to run the numbers on USAID countries, which, as Fitz pointed out, we are presumably assisting them to build their health systems. So how many U.S. private companies are actually recruiting from the health systems that we're also trying to aid with taxpayer dollars? And there, the number was quite astonishing. It was 87%. 129 companies are recruiting in those countries. And this is the breakdown of where they are. So 22 companies are active in Africa. This is an issue that on the Hill has been kind of glossed over. The recruiters have been asking for more visas. A few representatives, Senator Durbin, Senator Kennedy, have asked the question, well, where are you recruiting, and are we doing any harm when we do this? Should we think about that before we give you more visas? And in general, the answer has been nobody recruits in Africa or in the poorest countries of the Caribbean. And so this was important to actually document that there are 22 companies that have offices in Africa or are doing job fairs. So we also, the third part of the research was to do focus groups with the foreign educated nurses themselves. And these were really an unexpected litany of problems people are facing. And some of them are avoidable and some of them perhaps aren't. The first sort of set of problems has to do with foreign educated nurses' lack of understanding of how the market works. And so they tend to enter into agreements with recruiters that they meet at a job fair. They don't get a copy of the contract, they don't understand the contract, and one would agree that those are not ideal circumstances for contracting labor, but it is in fact the practice. So some kind of an effort to try to educate nurses before they enter into contract about what the best deal they could get would be. Some work in the Philippines. Part of the themes here. It's been a long time. Some work nurses to understand their rights and how the market works in the United States would be beneficial. The second issue is that these buyout fees have vulnerability. So even if one argued that the buyout fees are necessary, given the upfront payments made, they do create sort of the threat being reported to the immigration officials, or the threat of having to pay these fees is much more. The employer would do this, but it creates a situation where there's a lot more manipulation that's possible. And related to that is recourse. Educated nurses are fearful of unions. Most unions don't try to recruit foreign educated. So when problems occur, green cards are retained by employers, when passports are retained, they don't know where to go. And so there are some foreign educated nurse associations. The Filipinos have created a group of organization of these people and recourses in terms of learning about their rights. And the last set of problems relates to clinical and people in all cases, but in many cases thrown out onto the floor without sufficient documentation. In particular, there was coming from the Philippines who were in these long-term care facilities like the one you described your friend being in, with very acute patients. There were procedures and problems that they had never seen before, like bariatric surgery in the Philippines, and they were thrown out on the floor and expected to care for bariatric patients, and the level of terror that they faced in that process was avoidable if there had been good programs in place to help them adapt and integrate in their workplace. Code, and I probably am taking too much time here, I'll speed along, but the code, the idea was to develop a market-based instrument that would help change behavior of the recruiters. in the UK, in Ireland, Scotland, and Norway, they have decided to tackle this policy issue head on. In the last 8 years, we haven't had a government that was interested in doing that. But the private sector was, and in part it was because there's been such an up practices internationally that they had in their hands, much like the tobacco industry or the pharmaceutical. They were interested in changing perceptions of this business. So the idea was to market incentive that would modify the behavior of employers and recruiters, primarily to make sure that the rights of the immigrants were respected, but also for them to be cautious about where they were recruiting and how they were recruiting. So we convened a task force, Academy Health with O'Neill Institute, and Peggy was a member, and Katie was a member, and it was it included hospital associations, it included foreign educated nurse associations, it included the professional. And we, over the process of about 6 months, hammered out a document that everybody agreed would set minimum standards. We released the code this September, and we have the endorsement of pretty much all of the employers and recruiters. One of the side products of this was that the recruiters themselves formed an association. And while we were not asking for individual company endorsements, all of the major associations have endorsed it. So it was so far so good. And here's where we are now. We have two parts to the code, standards that we think need to be monitored. Companies that recruit, be they placement or staffing agencies, and employers who use recruiters or may recruit themselves will subscribe to the code, and their conduct will be monitored through interviews with the foreign educated nurses primarily. So that the section that it refers to minimum standards is the part for which compliance is mandatory. There's a second part to the code which is sort of aspirational in tone, and there are two parts to that. One is about sort of interesting models of giving back to companies and sort of the notion of corporate social responsibility. We simply documented some of the things that companies are already doing, but we don't have an evidence base about which of those practices is most effective, which of them are completely ineffective, and so we simply listed them as sort of think about this kind of thing as a compliance kind of measure. And the last part, which turned out to be quite controversial outside the task force, although the task force was very eager to endorse it, everybody agreed that it was important, was language around the idea that recruiters should be careful so as not to harm health systems. And in particular, it mentions the WHO 57 countries as countries that we about before charging into. The recruiters themselves were not, this was not controversial. They understood that if they were changing their behavior, they had to at least have an aspirational that referred to that. We had some press coverage in the Washington Post about the code. The Secretary of Defense of State wrote a letter to the Washington Post afterwards objecting the argument, and again, this is perhaps a good question for a legal scholar. The argument was that we were restricting the rights of immigrants by, in essence, not giving them equal access to a recruiter. And while the code sets out very clearly in the beginning that all, the sort of the acknowledgement of the human right to migrate, the notion that one should use caution in deciding where to recruit was objected to by the State Department. And it'll be interesting to see what happens with that position now. I think it related to a large degree to their negotiations at the international level with the World Health Organization, and I don't know to what extent you all are free to talk about that as well, but I know that the State Department has been adamant in opposing any mention of caution in determining where you recruit or not recruit, and so I think they felt that the U.S. private sector doing this was a slippery slope, and they made their voice loud and clear that they were Interestingly, the private sector didn't care and has moved ahead with this. So this is the list of organizations that were actually in the task force. And just briefly to close, to tell you where we are now, we're actually now in the phase of planning a monitoring entity. And we've set up a group which is, in effect, a subset of the task force that is a very well balanced, and this is really vote by vote balanced stakeholder transition group. And it basically breaks down into three sort of groups, voting blocks, if you will, caucuses, anticipating that not everyone is going to see eye to eye. So unions and the foreign educated nurses tend to have one viewpoint. The associations and accreditation and certification and licensure bodies can go either way, and some of them are very different from each other. And the employers and the recruiters tend to have another viewpoint. So the idea is to set up a governing structure that gives voice to all of those perspectives. There are a series of planning documents that we need to do, but the idea is that there will be an organization that's independent, that's set up, that will be financially self-sustaining because recruiters and employers will pay a fee to subscribe to the code, and they'll have their own governance system, and it'll become an independent initiative.
I think before turning to Pascal and Peggy, why don't we take a 5-minute break, because I know we've been sitting and listening intently for a long time. And if you can keep it to 5 minutes, that would be most appreciated. And we'll see you back for our last part of time.
Would it make sense to outsource the training? Consciously or not, what I'm asking is, from a policy, conscious policy, could you leverage your healthcare money better?
They do a lot of remote technology.
I'm heading off again.
Yeah, it was a good pleasure. Thanks very much. And I really like your work, so keep on reading. Thanks so much.
I'm surprised the term I know talking about partnership. And then really talking about solutions. You're talking about somebody trained to put an idea. Or they do a lot of that. Or they're trained to do another skill, and basically you're not really nervous, but you can do the hell out of that skill. Right. Take excellence.
Yes. Okay. So they trained But they're even more specialized than you might think. Like they'll take a girl and for pre-surgery counseling. One. You have to get out there with make your girl know that you do that one drop.
What was that like? People are over, and there are people that are like, beyond.
It seems like if they're just there together, we can just jump down and start jumping over people's heads, then we're up.
And then we get to understand, like, and like what things have to change or
From an efficiency point of view, it should be done at the lowest level where it can be done very, very well.
so,
Not the lowest.
I can imagine. I mean, they're there. You know what I mean? Otherwise, I always think like everyone's really the same. Like here's
There's naturally too much water during the fight. Exactly.
So, and it wasn't like, yeah, I think it was just like, very good. There's a lot of people on the list of this. And that was the majority of these are filmed in this area. Close to James area. It's like America's historical crime village. It's really
Everybody takes their seats. All right. Thank you, everyone. The problem is that everybody's gotten so fatigued that you started the reception. Before the reception. Never mind. We have two authors, both of them who traveled a long distance to be with us. Pascal from Geneva and Peggy has actually flown specially nearly overnight from London to be here for this occasion. And even so, she has graciously said that she virtually skipped her talk so that we can get our one. Our first speaker is the World Health Organization. He's an economist there, has worked at the OECD. He's been an enormously rich contributor to the Code of Practice at WHO and also in today's meeting with the Millback Memorial Fund. Thank you very much.
Thank you very much. I'm very pleased to be here. It's really a beautiful university. I wish we could have the same in Geneva. I'm going to talk about the WHO Code of Practice on the international recruitment of... it's still under development, so what I will present is a bit the background, some of the main features of the code. The code itself and all the details, as I'm not a lawyer, Ellen Taylor, who is here and has been involved very actively in the drafting of the code, we'll have a class on that, so we'll provide you more details on the specific legal aspect of the code. You heard before and many times by the previous presenters, 57, that magical number, 57 countries with critical shortage. So here's a map with those 57 countries. So as you can see, it's mainly those are the dark countries on the map, so it's mainly countries with critical shortages in Africa and in Asia, India, Pakistan, Afghanistan, some in Indonesia, and some in Central America and the Caribbean. So the background for the development of the code is the fact that there's a critical health workforce shortages identified by WHO in those 57 countries. In addition, as it was also mentioned, there's a strong migration, out-migration from many countries that already have a fragile health system. So here you cannot see, and it's normal because it's very small, but basically those are the out-migration rates of doctors, the highest of among those that have critical shortages. And among those are countries in the Caribbean and in Africa. So basically, for some countries, almost 80% of the health workforce have left the country. And if you identify a bit where are those countries, it's mainly Caribbean, African countries. There's one differences that still need to be noticed is that although some of the countries where the migration rate is the highest are the Caribbean, they still have a higher density of doctors remaining. So that means that some countries may have a very great out-migration rate, but still, despite this, they have still a lot of number of doctors that remain in the country. But African countries, they have a strong out-migration rate and not many health workforce remaining in the country. So, given that context, in 2004, the World Health Assembly, which gathered 193 countries, passed a resolution because it became clear that migration from those countries in general has some critical impact on their health system. And this resolution asked the Director General of WHO to develop, in consultation with member states and all relevant partners, a code of practice on the international recruitment of health personnel. So that started in 2004. And I think what is interesting to see now is a bit the development process of that code, and also that code, which is a global code, did not start from zero. There were already what we call code of practice. So just an example of existing code of practice that either were adopted before that resolution or that were adopted after. One of the first one was the UK Department of Health Code of Practice for International Recruitment of Healthcare Professionals that was adopted in 2001 and revised in 2004. It's usually referred as the UK, but it's mainly, as a Scottish friend of mine mentioned to me, it's mainly England. Scotland is not included in that. That code was revised in 2004 in order a little bit to include more the private sector. Those codes really tried was to provide some guidelines for the recruitment of health workers and to avoid recruitment from certain countries where there is a critical shortage. One thing that they realized is that was for the NHS, it's like the public sector, but the private sector was not included. So some people were recruited by the private sector and then moving from the private sector to the public sector. So in 2004 they tried to correct for that. Maybe the first really international code of practice is the Commonwealth Code of Practice that was adopted in 2003. It was also very interesting. There was a lot of discussion regarding that code of practice. In particular, one provision created a lot of debate. It was the idea of compensation. As it was presented before by the different presenters, when people are leaving the country, especially poor countries with already fragile health systems, it can create a lot of problems. And there was the idea to compensate for that. And it's a very political and sensitive issue. As a result, although there was a kind of agreement among Commonwealth countries for that code, at the end, among the Commonwealth countries, only one higher income country signed, was New Zealand. All the other countries, the United Kingdom, Australia, did not sign the Commonwealth. Then the NHS is another example that was adopted recently. And also, if we look at another region, the Pacific Code of Practice for Recruitment of Health Workers that concerned all the small islands within the Pacific. So Australia and New Zealand are not included. When we review those codes, they're voluntary. So that's on the one side a big advantage. On the other side, it's also a big disadvantage for them. But there is one of the feature. And they really tried all these codes to provide some guidelines for an ethical approach. And most of them focus on three things in those codes. The first one is to protect the right of the migrant workers from unscrupulous recruiters and employers. And Patricia Pickman, I think, by describing the code for the U.S. recruiters, really emphasized well that issue. Another one, which is already related, is people have the right information when they leave their country. It happens many times. You have many stories of people that will propose a job, and when they arrive in the country, the job they have is totally different. And the third one, which is also attracting a lot of attention, is the fact that we need to avoid that the recruitment of health workers from countries where there is already a crisis in terms of health workforce are suffering from that recruitment. So all these codes and, of course, the WHO proposal, they face some challenges. And I think there was a discussion about active recruitment. As it was mentioned, we basically face two contradictory forces. One is the individual right for anyone to leave his or her own country, and the other one is the right of health in countries. And combining those is not always very easy. So if someone leaves his or her own country, that will be a personal decision. If there's a very active recruitment, that will be another story. But to define active recruitment is something where there's no total agreement. Another issue is that a lot of times the codes do not cover all possibilities. We saw that with the UK one, the private sector was not included. So part of the recruitment, in some cases, is not covered by the code. Another challenge is the monitoring. How can we know that the impact of the code if we don't have the information? The issue of reciprocity of benefits, as mentioned before, for the Commonwealth Code of Practice, there was this notion of compensation. It was very political, and at the end, many countries did not want to sign that code. This is quite sensitive. And finally, the impact. Following the adoption of the code, do we really see a difference in the recruitment process, in the migration flows? So if we look for the UK, for instance, so this is the number of yearly registration of nurses in the UK. You have three different curves. The first one, the dark one, is the number of nurses that are registered on a yearly basis in the United Kingdom that were trained in the United Kingdom. So this is domestic. The second one, and this is very interesting, the light blue one, is overseas nurses. So that's the yearly number of overseas nurses that registered in the UK. And you can see a huge increase between 1993 and 2001. And in fact, in 2001 in the UK that year, there were more nurses that registered that were coming from overseas than from the UK. And then that decreased again. And you can see below, that's the nurses coming from Europe. So we might think, okay, the UK Code of Practice was 2001, the Commonwealth in 2003. So we may try to relate that to the code, the effect of the code. In reality, things are more complicated. They're always more complicated. What we have to know is that in the UK, they had a very ambitious or expanding policy to increase and develop their health workforce, including nursing. So what they did from the 90s, the end of the 90s, was to increase enrollment in nursing schools, increase also recruitment from abroad, and try to recruit back nurses that left the health workforce in the UK to have other jobs. So we had a bit all those different policies, and at one point there were also some financial problems because to have those policies on a continuous basis, you need a lot of financial resources. And in the beginning or mid-2000, that financial availability was not there anymore to sustain that policy. And in addition, some UK nurses that just graduated it was difficult for them to find a job. And another thing, this peak is also explained by changes in migration patterns. So if you look here, the next graph, it is just the evolution of the yearly registration of foreign nurses in the UK. So if I go back here and try to... So this curve is composed by the migration of different countries, which is here. And really make a big difference is the Philippines. So you can see that in 2001 there was a peak of migration of Filipino nurses in the UK that really went down. So there was not really a huge change of migration from countries with critical shortages. It was more a change of migration patterns from New Zealand, from Philippines. On the other hand, the other one that increased a lot is the migration from India. There's another country where there was a big change, and that can be related to an agreement. Africa. South Africa, there was a lot, this is the yellow line, there was a lot of, I'm sorry for the, I just realized that for you it should be very difficult to read, especially at that hour of the day. But just look at that line. Okay, now I don't see the, okay. That line, which is the yellow one, this is the yearly registration of nurses from South Africa. And this has really decreased over the years. And this can lead to a bilateral agreement between the UK and South Africa. So these bilateral agreements can have an impact. So we can see that there are many challenges for. However, having said that, code of practice, that is the WHO code of practice, would be crucial to really put the issue of international migration on the international scene and really favor the discussion. It will also contribute for regular dialogue between countries. And also, one of the purpose of that code is to facilitate, provide an umbrella for more stringent agreements between countries as MOUs or other bilateral agreements. So a time trend in favor of developing such a tool. So now if I look, it would be also very difficult, the development process. Basically, what is important to have in mind is it started in 2004, and now we're in 2008. So you can see it's a long process. It's a technical process. It's a political process. There were different steps. First, there was a draft of an outline that was developed. And here we had different steps. I will not go through all of them. Maybe I will mention one body that played a crucial role. Migration Policy Initiative. Peggy Clark was one of the key persons of that initiative. And we had different meetings that combined WHO, and Realizing Rights, NGO, and the Global Health Workforce Alliance, which is a partnership of different organizations. And together we developed a draft code and then a draft to have a outline. Then there was also a political process. It was presented to different meetings where country representative was there, either through WHO regional meetings or through ministerial meetings, Ministerial of Health. Then there was itself, and as mentioned before, Georgetown was heavily involved in that with Alan Taylor. There was what we called a public hearings. That's interesting that the idea was to display the draft code on the internet, on the WHO web page, and anyone could provide some comments. So you see, I will just go back, but just here, we received about 100 comments, some from countries, 20%, some from professional associations, some from academic institutions, NGOs, other international organizations. So that was very interesting and important through the web public hearings to have the feedback regarding the code of practice and in order to integrate those comments. So this is the recent development for the code. So July, August 2008, there was the writing of the draft code. In September, just the web-based hearing that I mentioned. And maybe what would be one of the final steps is that the revised draft code, a resolution, summary of the public hearings, all those documents will be moved and passed to the executive board of WHO that will take place in January. So this is, if you want, like in a way, the executive member of WHO. There are 32 countries, and they will make a decision whether to submit the code to the World Health Assembly in May 2009, or to decide whether more changes are needed. It's really the process. So now it's more a process that is in the hands of countries, not anymore in the hands of the WHO Secretariat. So for some of the main objectives of that code is really to promote voluntary principles for the recruitment of health personnel. This is something very important. Another one is really an instrument of reference for other codes, for more regional codes, and to provide guidance for the development, for instance, of bilateral agreements. To facilitate and promote international cooperation. I think this is a very important field that needs to be taken into account, and especially to recognize that some countries have a difficult situation in terms of health workforce, and this needs to be taken into account. Among some of the guiding principles, so as all those codes, it's a voluntary code. It is emphasizing the right of health workers to countries that wish to admit and employ them. So this is really recognized. The idea is not to suppress or strongly limit migration, and at the same time recognize the right to achieve a high health. Also, that recruitment can be justified. I mean, we cannot deny countries to recruit from other countries. It's part of the health workforce development. And also, what is important is that code in a way maximize the benefits of migration and trying to control or to avoid the negative effects of migration. So this is some of the guiding principle. Other one is in the terms of recruitment, and this is also what was mentioned with Patricia Pittman, that when there's the recruitment, the issue of transparency, fairness, and mutuality of benefits is very important. And as mentioned before, the specific needs of lower income countries with critical shortages are really to be taken into account. And finally, what is important, that code also places a lot of emphasis on the issue of data monitoring and the monitoring. Without this, the code will not, there will be no way to see the effect. So in terms of conclusion, I want to say that such a code is one approach to try to address the concern, but it's more the beginning of a process than the end of the process. And it's just one tool among others. Such a code will certainly not solve all the migration issues. We provide guidance, a platform, facilitate the development of new approaches. So if everything is is fine or goes according to plan, that's adopted in 2009 by the World Health Assembly. That's what might happen, but that might not happen as well.
Okay, well, we've clearly bit off more than we could chew. It's one of these things where you have magnificent people in town, and we didn't want to miss one of them, and so we virtually ran out of time without the students. So, Peggy, did you want to just kind of introduce Realizing Rights? And just a couple of questions from our international students, just so you can see what wonderful, magnificent students we do have.
No, but I'm
And
actually
then we'll
ceding
have
my
our
time
proper
to the
session.
students because I was so impressed when you started, Larry, by saying the first question gets to come. Just simply would say, my name is Peggy Clark. I'm with the Aspen Institute with the policy program there. We worked very closely with Pascal, the WHO, and the Global Health Workforce Alliance on an entity that, which is the Health Worker Migration Global Policy Advisory Council. And all of this magnificent presentation, it's extremely political. We have giving the best-in-class information to ministers of health from many of the 57 countries that are affected by this, as well as trying to educate on the Hill and elsewhere about these issues. They're deeply engaged in debating the code and what it means to them, and will continue to do so. I look forward to telling you more about that process as it unfolds and to hearing your questions and support.
Very generous. Okay, so Morgan, you've got the first question?
Sure. If any of you guys can speak about how the recession right now might affect education and the recruitment of medical professionals in the U.S. in terms of either being a more attractive career path, since it's, it doesn't really, it's kind of recession-proof with medical health, and also because of the loan and financing issues and the problem with the government trying to subsidize more spots in these classes where they're already not accepting everyone.
You know what I'd like to do? I think maybe I'll take a few student questions and then turn it over to the panel. I think that might be better.
I mentioned that the addressing the problem of health work and migration is the sort of the delicate balance between the needs of the communities and the basic rights of individuals to migrate and pursue careers abroad. Now, I think, Paula, you mentioned one such program, but I was wondering to what extent so international governments are working towards shifting the focus from themselves, sort of the receiving countries, to actually building capacity in the sending countries, sort of building schools, training, education, funding wages, and sort of settling that challenge in that way. So just making it more appealing to stay at home.
Did I understand that? But part of the point was the United States is not interested in its capacity to graduate nurses?
It's not a matter of not interested. It's really more a matter of, sorry, I'm speaking out of turn.
I'm going to take a few.
Okay.
I was wondering if any of the members of the panel are working, or some of the issues raised seem like the huge challenges to sound like clear violations of American employment law, contracting law. I mean, really, I'm surprised unions aren't more involved in advocating for these foreign populations. And so, is there an initiative, third-party violators, the people who bring the nurses onto their hospital floors? So, just any commenting about any activity in that area, legal activity, would be good.
Jackie, do you want?
I'm just wondering what strategies you have for donor countries to sort of like convince convince African governments to increase the salaries of health workers. Because to train health workers in Africa. But the point is that people in high school don't. First of all, they know that law school. They go to law school. They go to school. And then the nurses are getting, and the doctors are getting low salaries, so they can't actually afford medical school. So I'm just wondering, because you mentioned something like in Malawi, countries have been trying to like pressure governments. It may be in different sectors, for example, maybe in the NGO sector.
Okay, I think we've got enough questions. I'm very, very sorry for the time constraints. Why don't we just ask each member? Peggy, why don't you go first, since you didn't get a chance to talk?
Okay. Those are some fascinating questions. Maybe I'll take your question. I think that, when we started the Health Worker Migration Global Policy Advisory Council, we started by saying we believed that it was possible to respect the right of people to emigrate and also to respect the right to health in countries that were really hard hit by out-migration. And we have found there's a lot of room to move between those two poles. People immediately assumed we were saying that we were taking migration was bad. And I think the truth is migration is a natural phenomenon. It makes all as you're describing that someone would choose, for example, to immigrate in search of a better life if they could get a salary, which is often the case. So in response to your question, I think that the truth is that the answer requires, it cannot be solved by one nation alone. This truly falls into the area of global law and global responsibility and global action. And that's what we're trying to do with the code. That's what we're trying to do with other efforts. I think the truth is it goes beyond the health sector. It's often the development sector. It's USAID, DFID, the UK Development Agency, is the one who started that huge experiment in Malawi that's making a difference. So what's interesting about this is that we're at the beginning of practice. Like, what is happening that is worth looking at to see whether it works or not. My response to your question is that it is quite complicated to respect. We can't look at just one side or the other.
Pascal, would you want to?
Yes, maybe for the questions from Malawi. I think the issue of wages in countries, especially in Africa, is a key question. There are maybe two or three things. First, there's a huge gap if we compare wages in Africa and wages in the U.S. And this is clearly one of the factors of migration. So there's the idea to increase wages. To close the gap, that's not realistic because economically this is not sustainable. This is not sustainable for different reasons. First, on the long term, there will be disequilibrium in the budgets. And then if you increase dramatically the wages for doctors, all the civil servants we want the same. So this is something that is not easy to do. The experience of the DFID in Malawi is very interesting because it's usually donors don't want to finance wages of the Minister of Health. It's not really a long-term development. I mean, it's a bit of a new thinking of going in that direction because it raises the issue of sustainability. For how many years is DFID ready in that direction? Especially, and that was mentioning the economic crisis, some countries from France that is now the equivalent of the DFID, the French DFID is reducing its number of projects in Africa. So that's the problem with that. Some countries like Ghana have increased their wages. So there was, in Africa, there was a summit in Abuja. The idea was to have 15% of state to be devoted to health. And we know that about 50% of the budget of health is workforce or more. So that will mean increasing share. Of course, this will depend a lot on the economic situation. And now, short term, maybe not, but more in the medium term, we may have expect that it will be difficult to realize.
Okay, just maybe a minute or two from each because we're over time.
A lot of debate right now among nursing experts about whether the recession is going to lead to the shortage, because people who are in retirement or working part-time may come back to jobs. There's also the Workforce Reinvestment Act, which is federal funding that is to retrain workers that have been displaced by free trade agreements, primarily NAFTA, I believe. And there's nursing in that stream of money, and Obama has talked about increasing, or Obama's advisors have talked about increasing funding for that. And so that could be potentially a pot of money to do retraining of automobile workers or other kinds of workers that have been affected. Maybe the boss would say that that's not as easily done, I think. Should be worked up. There needs to be good thinking about what steps that would need to be taken in order for that to happen. People have sort of come down to it's a great solution and it's impossible without really thinking about the complexity. I'll let you do as the U.S. respond. On the contract law, I have asked so many lawyers this question and everybody out of it. And Larry, and I'm also, I think nobody's really an expert. Contract law, migration law, and labor law. I'm not a lawyer, so I don't tell you there's nobody that has sort of focused on this intersection. And I guess it takes some work to figure out the answer. I don't think anybody has a quick answer. So I would welcome someone looking into this.
There's got to be an answer.
Well, you asked about medical education, and nursing education are very different animals. Medical education takes a long time and is very costly. Actually, nursing education is very costly as well in terms of human resources, clinical training. But it takes a lot less time. And for people, as many of you probably already know, for people with baccalaureate degrees already, it actually doesn't take terribly. Program at our school that's 16 months. Some universities have programs that are a year to become a marketable skill at something that a lot of people, you could have a career for the rest of your life. So in that sense, it is a fairly recession-proof job. Getting to your question about faculty, it's not a matter of a lack. I think the U.S. It frankly, I think, is a matter of a lot of people feel that back to school to become a nurse is not just feel, but they don't make as much money as they do in practice. So an advanced practice registered nurse anesthetist graduating from a master's program and then eventually a doctor of nursing practice program, $170,000 a year. I can tell you that pretty much most nursing faculty make that much money. And they have to go to school for a considerably longer period of time. The incentives aren't there for people to become faculty in nursing.
So that's the restraint on the number of slots, not a conscious policy effort to keep the numbers.
Yeah. But Katie, if you look at Title VIII funding, which is federal funding for nursing schools, it has remained flat since 1975. Mm-hmm. So in real dollars, federal funding for nursing has declined.
Right.
Whereas
true
medical
as well.
education has increased. So at the level of the federal government, there's not a lot of it.
But, most nursing schools in the United States have significant faculty shortages.
The student union is going to get upset if we keep them over.
Okay.
Okay, adult time. Any final?
I'm just going to say
word.
So just queried at our meeting today whether investment in healthcare worker education and healthcare employment could be part of a stimulus package in response to the financial crisis. I'll leave you to think about the answer to that, but we wondered if that was actually quite a positive look at the financial crisis, and maybe there's scope for some pitches health education and the health workforce to stimulate the economy.
Bankers, car companies, nurses. Okay, well, thank you very much. And now we can officially have our